Hello, welcome everyone. Good morning. Welcome to the um, CPD LMP University of Toronto Hematopathology Community of Interest Group meeting. Today, I would like to introduce our speaker, Dr. Carlo Hojilla. And Dr. Carlo Hojilla is an assistant professor at the Department of lab medicine and pathobiology at the University of Toronto. He's trained in anatomical pathology with a fellowship training in hematological pathology. Dr. Hojilla is actively involved in the University of Toronto residency and fellowship training site. He's the director of the Digital Library of Medicine, which is an annotated educational database of the pathology whole slide imaging. Currently, he's completing a master's in educational focusing on technology enhancing learning and evaluation. He received the Canadian Association of Pathologists Leadership in Education Award in 2021 for innovations in online pathology learning, including the creation of national teaching rounds, academic pursuit, additionally including lab quality assurance, pathology informatics, and workload assessment. Today, the title of our talk is Reactive Lymphadenopathy, expanding the differentials in the light of emerging entities within the Castleman disease spectrum. Of note that our previous talk, which was scheduled for cutaneous lymphoma, has been rescheduled by Dr. Adil Ahmed due to unforeseen circumstances. So we will be sending the date soon for the scheduled talk that was scheduled at that time. So I would like to welcome Dr. Hojilla and would like to thank him for his talk today. Carlo, the floor is yours now.
All right. Thank you, Sadaf. Welcome all. So let me explain a couple of things. First of all, very informal setting, everyone. As you can tell, I'm wearing a baseball cap, but I'll move in closer to the camera. If you can see what the baseball cap says, it is indeed National Med Lab Week. And so I hope wherever you're at, that your department and your hospital are celebrating the great work that we do. And Sinai made hats for us. So I don't know what kind of swag, and if you're willing to share that on screen, please do so. But it's all a celebration this week for National Med Lab Week in Canada. So congratulations all, self-pat in the back. Yeah, so let me start off by saying hello and thank you to the organizers. And I'm going to launch a poll because I love polls. I want to see what kind of audience that we have here. So I'm going to launch the first one. So to all joining us, who are you? I'd like to see just in terms of the audience that we have. We'll try and get um, information kind of covering many different. So we'll do about 10 more seconds. Oh, I guess that was done. All right. Sharing the results. All right. So most staff, welcome to everyone. We have some medical student, some resident, and then other. I'm not sure what the other is. If you can put that in the chat, that'll be great. What do we have? Community pathologist. All right. Wonderful. Okay. And then the other one might be a bit more practice specific. Sorry, we'll stop the share and we'll launch this one. Regarding your clinical practice, if you're a clinical staff. So yeah, so amazing. The reason I was asking about this is because the topic that we're going to be discussing today, I think, touches on a lot of different fields. And it also speaks to the general knowledge that's available in the audience here, which is amazing to see. And hopefully you'll find something quite useful, regardless of where and how you're practicing with this talk. So thank you for setting that stage for us. I'm going to take off this hat because it's actually pretty hot. But yes, happy Med Lab Week, everyone. There's the hat. There you go. All right. So we're going to be talking about reactive lymphadenopathies. So just some disclosures here. I do have some speaker fee and honoraria, none of which will really factor into this talk, nor am I going to be discussing any off-label drug use. What would I know about that? I'm a pathologist. Regarding learning objectives, basically, we're just going to review the current diagnostic and clinical criteria outlined in the current guidelines for the diagnosis of multicentric Castleman disease, explore some differential diagnoses for Castleman-like histopathology changes in the lymph nodes, and then evaluate newly recognized entities within Castleman disease spectrum, including really complicated acronyms like TAFRO and IPL, and then go through some discussions later on. So I guess let me start off by posing the challenge, right? So reactive lymphadenopathy. I think we all have an idea what that is, but sometimes it can raise certain issues. I think most practically speaking, the most common one that we'll encounter are an issue of quantity, right? In especially in modern practice nowadays, it's not uncommon that we get lymph node biopsies as just needle core biopsies. Depending on where you are, sometimes those biopsies are bigger, but for the most part, there's an issue of quantity that we have to deal with these types of tissues versus, like bigger things like excisions or incisional biopsies and things like that. There's of course mimics that get raised in the differential. As we all know, not all reactive appearing nodes are actually benign nodes. And there's histologic patterns that can overlap significantly between those different reactive processes as well as systemic diseases. We always worry about those red flags, specifically more on the clinical side of things. So, how persistent have the symptoms have been, any acuity in their presentation, any in terms of those nodes that we're seeing, as well as histologically, right? Like, are we seeing things that are not necessarily in keeping with reactive, right? If we can see those big, ugly, malignant anaplastic pleomorphic cells, sure, that's easy. But I think there's a lot more nuance when you're looking at normal and whether this, how is too much, when is too much too much? So things like plasma cells, fibrosis, vascularity that pops up, those are things that also inform our differential. And so the goal here is to really kind of bring up some of those differentials beyond just simple reactive lymph node hyperplasia, which is a common diagnosis that I often render, especially when you're seeing things like these Castleman like features. So I'm gonna just put it out there. I'm not a big fan of this term Castleman like. I really resist the use of this term as much as I can because as we'll go through later on, I think it leads to some more problems, and especially nowadays when the diagnosis of Castleman is not as straightforward anymore. So Castleman disease, a brief overview. Basically, it's a relatively rare, heterogeneous group of lymphoproliferative disorders, first described by Benjamin Castleman in the 50s, and it's very characterized by a specific lymph node histopathology. So you might have seen a hint of that with my little cartoon in the beginning. This is American data, and we don't have Canadian data, but it's relatively rare. So it's about 900 to 4,200 cases per year. And the real crux here, though, is that the presentation of Castleman or multicentric Castleman specifically is quite variable. And we'll go through what those the spectrum of those symptomatology are. And so because of that, that explains the big range, and maybe it's even a bit more underrepresented than this actual number is. So it's amazing to go through this history because, as the panel explains here, and much like anything in pathology, really, I'm sure everyone can appreciate this. In the 50s, it was just this description by Benjamin Castleman of lymph node hyperplasia resembling thymoma, right? And then very quickly after that, well, relatively quickly, there was this diagnosis of a giant lymph node hyperplasia, which I think is just a great histologic term, being divided into hyaline vascular versus plasma cell type. And then this GLH diagnostic line kind of persisted through the 80s. And then it's really in the 80s where this division between unicentric versus multicentric started happening. I would like to point out also that in the 80s was actually the first description of what we know now as this idiopathic plasmacytic lymphadenopathy. So we'll go back to that one. But around the 80s is when you had this distinction between uni versus multicentric Castleman. Um, then that kind of progressed 20 years later into the 2000s, where you now have this division of multicentric Castleman. So, as pathologists, we love to divide things and slice up that pie into smaller, smaller slices, for better or worse. But this is when you start seeing more kind of contemporary terms, so to speak, right? So HHV was a characterization that started um, really kind of dividing up some of the multicentric Castleman diseases, as well as this idea of like the secondary causes, which we now know to be exclusionary type things. And then again, as it continues, then this is when that whole characterization of, hey, we're seeing a lot more plasma cells in a lot of these cases. So maybe that's something. And so that's where this idea of what the plasmacytosis and where this fits into this general schema started happening. And then finally, in around 2017 is when the the Castleman Disease Collaborative Network brought together a lot of brilliant minds to formalize and provide some structure in terms of the diagnosis of multicentric Castleman disease. So this unicentric side, pretty standard, but everything else after that, recognizing the importance of HHV8, as well as the different mixed pathologies and things like that. And then we get to 2022, the most recent classification that really formalized this this idiopathic MCD into the different types. You've got the TAFRO, the IPL, the wastebasket NOS category. You've got POEMS being there, as well as the exclusionary diseases. Suffice it to say, it's confusing, right? Head's already starting to spin, and almost like, hey, it's nice to have that giant lymph node hyperplasia term again. But it is what it is. This is what we have. And I'll show you the decisions, I guess, the decision tree that led to these types of classifications. So you can think of Castleman classification in three different ways, right? One is the clinical classification that's been around since the 80s, essentially, right? So you've got the unicentric versus multicentric distinction, where you have unicentric, as the name implies, very localized lymphadenopathy, or often surgical resection is the cure, right? Whereas the multicentric Castleman has this generalized lymphadenopathy presentation affecting multiple stations. And this is really more the ones associated with a systemic inflammatory type of presentation. The other etiologic classification you can think about is whether it's HHV8 related. And I kind of present it this way because this is kind of related to some of the diagnostic workup that's going to be required for some of these things. But one easy way would be, is it HHV8 related or not HHV8 related? So we're not going to be talking about those HHV8 associated malignancies or lymphoproliferative disorders, because that's a talk in and of itself, but it's very, very interesting and nonetheless related. So for the most part, we're going to be talking about those HHV8 negative cases for us here, excluding certain things like the POEM syndrome that we'll get into a bit later. But hey, we're pathologists, right? Or at least most of us here, and we're interested in pathology, pathology adjacent. You can think of it too as something that we learn in first year maybe of pathology training, is that there's the very distinct classification system and very distinct histopathologic classification for the different types of Castleman. And then there's some loose relationship with the clinical presentation, where you have this hyaline vascular type, also known as the hypervascular type now. And I actually prefer this hypervascular type because I think that's the more accurate kind of depiction of what's actually happening. You've got the plasmacytic or the plasma cell type. But in all honesty, I think the ones that I've seen most commonly and most recently, they're often the mixed type. And so that's the spectrum between these. So part of that CDCN framework was codifying a lot of these histologic features that we have, right? If you go through that manuscript, it actually goes through the grading of all these different instances. I personally do not grade. I'm not sure if there's people that grade these things, but it's a nice exercise nonetheless to show that, to highlight that these really are a spectrum of changes. So you've got on one end of the spectrum, you got the hypervascular, hyaline vascular type of pathology. And on the other extreme, you've got the plasmacytic, plasma cell type of um, pathology, histopathology. And then you've got these other histologic features that kind of, it's not perfect, but it kind of maps out to where these histologic classification patterns are. So the hypervascular are more associated with those regressed germinal centers with some follicular dendritic cell prominence. You've got on the other end, you've got the more hyperplastic reactive looking germinal centers, and you've got the plasmacytosis as well that goes in there. And the vascularity is also quite a spectrum in here. Obviously, there's more on one side, there are more sclerosed and things like that, so more chronic type of change. But there's also some vascularity associated with the plasma cell type because that's how plasma cells get there. And so you've got just some images, again, part of that publication. All right, poll number 3. So just as a review, so which of the following is not a commonly used classification for Castleman disease? I'm going to start off easy, folks. So one of the neat things about Zoom is that as a host, I can see the answers coming through. These are all anonymized, by the way, so don't be shy. But it's just kind of neat because it kind of helps frame my discussion. But it looks like we have a very keen audience today because I'm going to share the results and it's consensus here, right? So yeah, so thank you. So yeah, so again, there's not anymore this giant lymph node hyperplasia, as alluring as that name might be. It's not there. Thank you for that comment in the chat. Somehow, yeah. Yeah, sure. By all means. GLH. All right, continuing on. Thank you for participating. So idiopathic MCD, basically it's been recognized as a distinct form from the HHV8 positive MCDs. And it truly represents a spectrum of disorders with a lot of overlapping features. So the current classification subdivides them into these type of syndromes. The IMCD TAFRO, also, which stands for this really nice acronym: thrombocytopenia, anasarca, fever, reticular fibrosis or renal dysfunction, and organomegaly. IMCD-IPL, which is this idiopathic plasmacytic lymphadenopathy. And then you've got the wastebasket, the NOS category, because obviously not everything falls in there. I think what's clear here is that really these are emerging entities that is only beginning to be recognized. And so hopefully we can end up with a better classification as these cases kind of start coming in a bit more. There's actually even talk whether these actually belong within this category. But again, these are relatively new classification systems that we're encountering right now. So again, just to kind of place that where it is in the current classification that we have. So you've got on the bottom here is the most recent classification where you do have these different types of IMCD and maybe even different types of TAFRO. So again, it's a bit of a jumble right now. And I think that's part of the confusion as well. Right. So regarding the diagnostic criteria, this was an international evidence-based consensus criteria published in 2017. Again, very, very smart minds met to talk about this with the goal of essentially standardizing the diagnosis, treatment, and research. It requires a major criteria, a minor, and exclusion criteria. And we'll go through those different ones because I think it highlights something very neat for pathology. So, nearest I can tell, this IMCD probably is one of the few criteria systems that has histopathology as a major criterion. So this one, the first major criterion, and you need two of them, is that you need this characteristic lymph node histopathology with those spectrum of features that we're going to talk about. That's the first one, right? So I think that's pretty cool, and it really places the role of pathologic diagnosis front and center. Then, of course, as the name implies, there's the multicentricity of it all. So, in large nodes with this radiologic kind of criterion of greater than 1 centimeter in the short axis and more than two nodal stations. So that's the first, the major. And then you've got, of course, all these features that fall in the spectrum that we talked about, whether you're looking at the hypervascular end or the plasmacytic end, as well as the mixed. Then you have the minor criteria, and this is where the lab part gets in. Also, pathology adjacent, of course. And you only need more than at least one, but sorry, at least two of the 11, with at least one of them being a lab criterion. So there's a whole host of them here. I changed the units to reflect Canadian practice. But the most important ones, and usually what brings these patients to the attention of a healthcare provider, are the CBC or the cytopenias, right? So you've got the thrombocytopenias, the anemias are usually what brings them into the clinic. So these are almost always there. And then you've got a whole host of other ones. So again, this very inflammatory picture. So it makes sense that CRB is elevated. You might have some renal dysfunction. Depending on the subtype, you might have like really, really impressive hypergammaglobulinemias. And then you've got the clinical criteria as well, where you have the constitutional symptoms, palpable spleens. Sometimes you can have fluid accumulation or some kind of fluid overload, and we'll get into that. You have some skin changes as well, and even some respiratory, potentially respiratory presentation. And number 4. Okay, what do we have? So just again, as a review. So which of the following is a required major diagnostic criterion for IMCD as per the CDC and guidelines? So this was just the previous slide. Good. Yeah. So one of the major criterion, as mentioned, is pathology, which is nice, right? And then this idea of multicentricity. So more than two nodal lymph node stations with the radiologic criterion for an enlarged lymph node of at least 1 centimeter in the short axis. So yeah, so IL-6, which will become important later on in terms of treatment, is not. It's a nice criterion, but it's not required. And HHV8 is, again, just a whole different classification system, if I may. So, and yeah, the other ones as well are not. So what we're looking for here is the multicentric lymphadenopathy. All right, so moving on. So these are the ones that are the select additional features supported of, but not required. So IL-6, and the reason that someone might have brought this up is because one of the potential treatments for IMCD is actually IL-6 blockade. So either a monoclonal against the IL-6 antigen, cytokine, sorry, or the IL-6 receptor itself. And then you've got other ones here that can all be done measured serologically. In Toronto, I'm not really sure where to get IL-6 serum levels except for sick kids. And it's kind of expensive as well. So please put in the chat if you know where you can get IL-6. Reticulin fibrosis of the marrow, again, is kind of nice because it helps, I guess, substratify the classification system. And then you also have a whole host of mimickers or disorders that have been associated with IMCD. And so this is part of where the confusion lies as well, because the clinical presentation has a lot of overlap. And then the final category is the exclusionary. So this is straight out of the publication itself, the CDCN guidelines, but I added a few other things because it has kind of just exploded in terms of what you need to rule out. And I think this gets the crux of a diagnosis of multicentric Castleman. I think as pathologists, Castleman features are pretty straightforward to see, especially the hyaline vascular type. And, I think we teach our residents that, oh, as soon as you see that lollipop, that's it, it's Castleman. But I think it's very challenging to do that, especially when you kind of add the clinical layer to it, because there's a lot of mimickers. And we'll go through some of the evidence of why that's valid. But basically, you have a whole host of autoimmunes that have autoimmune disorders that have overlaps with this. The most common one being rheumatoid arthritis. IgG4 is a big one, especially when you have those plasmacytic variants. HLH, macrophage activating syndrome, out of onset stills, all will have you, will always, almost always give you this reactive look that may or may not include these so-called Castleman-like changes. You've got the infectious ones, right? So acute CMV, acute EBV could potentially look like this. Toxo can also look like this. HIV and TB, especially when you're getting more into the hyperplastic kind of look, or hypoplastic GC reactive kind of look, you can have some of this. And then you've got, of course, the malignancy. That's the one that we worry about most, right? Making sure that there's some malignancy mimics that can potentially overlap. The most important ones, of course, are the Hodgkin and non-Hodgkin lymphomas. There's an association with Castleman and follicular dendritic cell sarcomas. So, might be good to look at those follicular dendritic cells and making sure that they're not dysplastic looking. Because of the plasma cell excess, you have to rule out some kind of plasma cell dyscrasia and assess clonality in those settings. And again, if you're considering HHV8 or there's HHV8 positivity, then Kaposi's also goes into that differential, because also you can get, especially if it looks really vascular, then just take a look at those endothelial cells, making sure that they're not atypical looking and things like that. So what are these Castleman-like histologic features? So to the keen audience, this is not just a funny Ghibli style image, but it represents at least three of probably the most specific ones. So you've got those regressed or hyperplastic, depending on which spectrum you look at, but for the most part, regressed germinal centers. The twinning is not something that you often see in the textbooks, but I find that that's a very specific one. So here, a picture of the twins. You've got interfollicular vascular proliferation. And again, these are the high endothelial venules, and you'll see them quite a lot, especially in the interfollicular areas. Along with that, you get the plasmacytosis because that's how they extravasate and go into the lymph node. You got this onion skinning that we know of. So hence the onion in this one here. And then you've got this single penetrating sclerotic vessel that gives you this lollipop look. So I think for the most part, as most of us are staff here, but for the med students and the residents, these are very, very nice and hint highly examinable pictures that you can get on slide exams, because they're quite specific. And so we'll show that again. But before this, let me ask the audience here. In your practice, which of the following histologic features do you consider most specific for Castleman? And so this is a multiple choice. So it's a nice way to kind of poll the audience here, because I'm always curious, because my specific features might not be yours. So it's always interesting to kind of see what the community has to offer. So this is very cool. So I think, yeah, so as you can see, most people, would think of the onion skinning. That's the most commonly picked answer. And I agree. I think you don't really see that onion skinning literally anywhere else. And then it's a tie between the twinning and the vascular, interfollicular vascular proliferation. Definitely not so much the hyperplastic GC. So that tracks. I think that's certainly something that I won't necessarily pick up on as well, just because that's usually more associated with other things. But yeah, so thank you for sharing that. So it's kind of neat. So we're gonna go through these features just for the because I know we do have some trainees as well, and it's just some nice review. But in any case, this is Castleman, and in my opinion, it's a fairly low power diagnosis, right? And so this is why um, one of the things is I hate to render this diagnosis on a core because you really need that low power kind of overall architecture that it's very hard to appreciate on a needle core biopsy. If you're lucky, yes, and I'll show a case later on like that's like that. But for the most part, ideally you want to see all these many atretic or atrophic germinal centers on a low power, right? Like you don't have to hunt for it because it just jumps out at you. So for the trainees out there, so these are germinal centers that are very, very small. I don't have a scale bar here. My apologies for that. But you can also start to see those other features that we talked about just in this picture. But on high power, this is what we're talking about when we say onion skinning. You've got this nice concentric lamelations within the marginal zone areas. And they're nice and parallel, actually. And I'll show you a CD21 stain that really shows this kind of almost train tracking. But this is what that onion skinning is. Like, if you peel onions, it's nicely concentric layers. And this lollipop idea that you've got this single penetrating, sometimes sclerosed vessel through that germinal center, providing you this look of a lollipop. In this case, it's a sideways lollipop, but you can see, the the handle here, and then you've got that nice swirl. Pathologists love food eponyms, right? So these are my favorite food eponyms in pathology. Oddly weird tasting combo, but sure. And this is that CD21 stain, right? Again, just showing you this train tracking, this concentric lamelations, the train tracks, onion skin, whatever you have. But CD21 brings this out nicely. I like CD21 too because it highlights the follicular dendritic cells. And it's a nice little quick screen that you're not missing some kind of follicular dendritic cell dysplasia, which could be a precursor to sarcoma. But yeah, nonetheless, it makes for really nice pictures. You don't have to, but it's nice. This is that high endothelial venule proliferation. So just to orient everyone, you have a germinal center, a trophic germinal center on the bottom left-hand corner here. For the most part, you don't have this degree of vascular proliferation in the interfollicular areas, which is the T cell areas as well. But this is also where just highlights this proliferation that you have. And these are all the venules, so the small caliber vessels that are just highly increased, right? Um, so that's also one of the H&E features that you can see. And then this is that concept of twinning. So in this case, it's actually tripleting, but for the most part, it's just usually two germinal centers. And I don't know if this is a collision effect where you have two germinal centers nearby each other, or maybe this is again because Castleman inevitably is a failure of the immune response to form properly. So is it this two germinal centers that just could not form, or like an overcompensation of the lymph node to try and form more germinal centers because it just can't. I don't know, but I think these are actually one of the more specific features that you see, the so-called twinning. And it's a twin because if you do a CD21, they're actually encased in just one follicular dendritic network, which I kind of have here, at least for this one here. So it's a bit more of expanded. And then plasmacytosis. Often that's accompanied by a color shift that you would see here. This is a bit more dramatic, but hopefully in the center here, you'll see plasma cells, right? And then just this more eosinophilic look because there's just a lot more cytoplasm. And then you see them in and around where the vessels are going to be, right? Because that's where they're going to be coming out from. So that's where you likely see plasma cells, just as you would in a normal reactive lymph node, right? That's where they're going to be most of the time anyway. So then just going back, this Castleman-like morphology essentially can be seen in a wide range of conditions. As we've talked about, you can just see them in just reactive lymphoid hyperplasias with just non-specific, but they can be associated with viral etiologies, as I mentioned before, you can see them as well in bacterial one, depending on how chronic the infection could be. Same thing with fungal and parasitic ones. You can see them in autoimmune. So rheumatoid arthritis related lymphadenopathy is very, very common in terms of seeing that. Um, Usually it's a follicular hyperplasia with sinus histiocytosis with some plasma cells. Lupus is more necrotizing, so you might have overlaps there with infections. IgG4. We're not going to go so much into IgG4. I will discuss that when we get to the IPL side of things. But IgG4 is a great mimicker. It's almost part of my routine workup now whenever I'm seeing reactive with slight increase in plasma cells. And then you've got, yeah, all the other inflammatory diseases. Like I said, lymphomas, non-Hodgkin and both Hodgkin lymphomas go into differential, at least of ruling out plasma cell dyscrasias as well. And then you've got all these specific syndromes that we'll talk about. Yeah, so when you get into a reactive look, probably the most common one that I almost always try to rule out through whatever available means that you might have is an autoimmune, because those are the ones that are just going to be the greatest mimickers, in my opinion. Most commonly, probably rheumatoid arthritis. I've seen quite a few of those cases that come in. And, sometimes it's easy enough because you'll find a big autoimmune workup, maybe some clinical notes suggest or saying that this is rheumatoid, or in the case of lupus, that these are all kind of been worked out, but sometimes it's not. So it's something that you might have to raise as part of the differential when you're seeing these things. Lymphomas, again, depending on the sampling, of course, hopefully will be pretty straightforward. One word though is just, again, when you're limited with cores, right? Sometimes those infiltrates can be a bit more monomorphic than usual, and so that might raise a differential as well. IgG4, there's more recognition of it now, so sometimes you'll get requisitions that come in, rule out IgG4. Whether that's real or not, I don't know. But you'll often see terms like storiform fibrosis or obliterative phlebitis, which you don't really see in lymph nodes. These are terms that were described classically for the pancreatic IgG4 related disorder. So it's a whole host of fibrosing disorders. And this two terms specifically, the storiform fibrosis and the obliterative phlebitis, was described with the pancreatic IgG4 related disorder, not so much in lymph nodes, but I still put it in. I don't know why, just negative for all these things. But the key thing that you can see is the change in IgG4 composition, IgG4 positive plasma cell composition, I should say. So whether you're looking at it in the relative sense, so against IgG positive plasma cells, and the criteria is greater than 40%, or the absolute, which is greater than 100. You'll find different thresholds for different organ systems, because again, IgG4 is what we now know as a fibrosing disorder that can affect, entities that we recognize in the lacrimal gland, into the salivary glands, to retroperitoneal diseases, to pancreatitis or some form of pancreatitis in the past. Yeah, so these are all now categorized as this IgG4 fibrosing disease. And along with that as well as a lymph node presentation. And then finally, yeah, some infections as well. HIV is a big one. Hopefully TBs and necrotizing granulomatous diseases and things like that is an easy differential, but still something worthwhile to mention. So yeah, so we'll go into some of the newer entities now. And TAFRO, aside of the fact that it has a very, very cool acronym, it's a relatively recent characterization. And the acronym stands for thrombocytopenia, anasarca, fever, reticular fibrosis, or renal dysfunction, and organomegaly. So most often these patients would present with thrombocytopenia, and so that that would be the big cause of concern. The anasarca or the fluid overload can come in different ways. It could be a full-blown anasarca, which again would require clinical attention, but sometimes they can be as simple as small fluid collection that's not recognized until you get the imaging, like a chest CT imaging or something like that. Fever often is the same type of B symptoms type of fever that you would get, so greater than 38. Um, and often persistent. The fibrosis, the reticular fibrosis in the marrow is interesting because you can imagine someone coming in with thrombocytopenia um, that they get marrowed, right? Because it's like rule out MDS or something like that because they couldn't do anything. Um, but often it's like couched in the sense that why would MDS be so inflammatory looking in their clinical picture? But nonetheless, maybe it's a superimposed MDS. Who knows? So that's why you'll get this association as well. And then the organomegaly is also a reason why people tend to get marrowed because, hey, there's lymph node stations that are enlarged or the spleen is enlarged. This must be a lymphoma. And of course, we diagnose lymphomas in the marrow, right? It's not. Um, so yeah, so that's usually that's the it's a very specific constellation of symptoms actually for TAFRO. So yeah, so they can clinically present as acute or subacute in onset. Often this very inflammatory picture, which is again very unique. Thrombocytopenia is the hallmark, often requiring transfusions. You have this some kind of fluid overload, fluid retention type of problem. Um, and then you've got this kind of, again, this inflammatory look of fever, elevated CRP and ESR, as well as the hypoalbuminemia. And then you can also have towards the later stages the disease with some renal dysfunction. We'll skip that one. And then the histopathology is also quite interesting because most of the time it's actually mixed. You'll see the combination of the atretic follicles that you would see in a hypervascular type, but also the plasmacytic look. So you've got a mix of the nice lollipop follicles, and you've got an increased plasmacytosis, interfollicular plasmacytosis, and sometimes you can even have some hyperplastic terminal centers in there as well. It's at least the TAFRO cases that I've seen, bona fide TAFRO cases that I've seen, has always been a mixed phenotype, which is reassuring because at least you can recognize the Castleman. The bone marrow. So can you diagnose this, or can you diagnose Castleman or TAFRO in the bone marrow? You don't have the same type of histologic features, but at least from what's described and what I've seen from my practice specifically, is that you get this megakaryocyte hyperplasia, and I'll show you later on. It kind of looks like MPN, honestly, or myeloproliferative neoplasm, where you have an increased hyperplasia of megakaryocytes that can look like MF or myelofibrosis. And then you also have the superimposed reticular fibrosis, which I think what we know now, or at least the hypothesis, is that this is actually more inflammatory immune-related type of myelofibrosis. So similar to what you would see for like autoimmune myelofibrosis or something like that. That's kind of what I equate it to. And in fact, in the past, not often, but I did render diagnoses of like autoimmune myelofibrosis. And I wonder, knowing what we know now, whether those were actually cases of TAFRO that just was not recognized as such. This IPL, or idiopathic plasmacytic lymphadenopathy, personally, I haven't had experience with this. I've raised it once as a differential just because the picture fit. But again, I personally don't have a lot of experience, and please volunteer if you have seen this in your practice, because I think that's a worthwhile discussion to have. But really what did it for me was the thrombocytosis and this marked polyclonal hypergammaglobulinemia. So on average, about 35, greater than 35 to 45. But I think the one that I saw had like 58, so really high. And then you have this generalized lymphadenopathy, also mature plasma cells. and an increase of them. But yeah, these are the main characterizations. Again, this is just from what's out there. I personally haven't had any experience with this, but you're supposed to see some preserved basic node architecture. And the key is this increased plasmacytosis, polyclonal plasmacytosis. You've got more normal or hyperplastic looking germinal centers. The vascularity is usually less prominent, which again kind of makes sense. And then this one, the hemosiderin deposition, this was highlighted in a few papers. So it's something that I pay attention to, whether I do a Prussian blue on all my lymph nodes or, you get them on marrow, so that might be something, but probably not on lymph nodes. It's not something that I would typically do, but who knows? Maybe that is part of the future workup. So clinical and laboratory features for IPL, again, kind of milder, this milder, kind of septic, infectious, inflammatory picture, however you want to call it. But the key is this hypergammaglobulinemia. So high IgG, that's polyclonal. The thrombocytosis, which again reinforces this very inflammatory picture. You can have some kind of fluid overload, but again, supposedly not as much. And I don't know what as much is really compared to TAFRO or the so-called NOS. But generally, they considered an indolent type of disease. So again, this is all highly debated right now, whether it actually is part of it or if separate altogether. Are we looking at a plasma cell type of IMCD really, and it's within that spectrum? But the key thing here is to recognize that it's actually of the TAFRO, or sorry, of the MCD um, classifications or entities under that spectrum. It's the one that responds really well to IL-6 blockade. Um, the treatment of IMCD has been complicated, to say the least, for the most part, because a lot of these patients show up with symptoms that are non-specific. Corticosteroids are usually the main treatment kind of modality until you figure out what's actually happening. And there are more targeted ones, and especially IL-6 is the one that supposedly is more specific or can respond. This can respond to IL-6 blockade more specifically. The big one, I think, from pathology side of things is just because you have the increased plasma cells is to rule out IgG4 related disease or plasma cell dyscrasias. And again, you have some overlapping features that hopefully will also help you sort these out. Um, so again, the hypergammaglobulinemia tends to be more associated with IPL. And then you've got the different serum IgG4 to IgG ratio that can hopefully give you more of an indication of whether this is IgG4 disease um, rather than IPL. So you've got the ratios of greater than 40%. And if you have tissue, hopefully you'll have both that seen available as well as serologically, as well as you can get those absolute numbers of IgG4 positive plasma cells. And then, yeah, you've got other clinical criteria associated with it as well. All right. So I have a few cases, and so I have a few cases that I can discuss now or discuss later. Let's just finish the presentation if that's okay. I'm asking Rosemarie and Sadaf if that's okay.
Yeah, sure. Please go
Yeah.
ahead, Carlo. I think
Okay.
it's fine.
I think almost done with this talk. So, um, so this I started the talk by saying I don't like this term Castleman like. I personally do not use it. It's something that in the past I've kind of used and only to find out that it was taken by clinicians as proof that this is Castleman disease. So I try to avoid that as much as I can. Either I just say Castleman or I kind of describe features of Castleman without saying Castleman. It's one of those things. So does it matter? Why does this matter? A recent study based out of Italy where they looked at over the 20-year history, they pulled every single Castleman or Castleman-like search term in their LIS. They found 48 cases where they used those terms. And then they looked at what the disease eventually became. Okay, so this is the breakdown of their findings. So 60% of where they used the term Castleman or Castleman-like actually ended up being Castleman disease, and this is the distribution within that umbrella of unicentric versus multicentric, or even HHV8 MCD. So about 60%. The rest of them, and I think this gets to the crux of the issue here, was deemed eventually something else. So let's begin with autoimmune, right? So 11% of those cases actually ended up becoming or related to autoimmune. Most commonly was rheumatoid arthritis or ALPS, um, autoimmune lymphoproliferative disorder through FAS sequencing or some kind of lymphocyte activation testing is how they found that out. IgG4, not that uncommon, but it was there. And then even cases of nodal marginal zone was the eventual diagnosis. And then even the highest here is reactive lymphoid hyperplasia. I think this is probably more of an NOS category, to be honest, that maybe they just didn't get the same workup that they got to figure out, whether there was some autoimmune markers or ALPS related testing and things like that. And so they were just deemed as reactive lymphoid hyperplasia. So I think for that reason, I personally, like I said, will be very careful with throwing terms like Castleman or Castleman-like, especially in the absence of any other kind of clinical history or serologic testing or fancy specialized testing or something like that, just to be sure. Or at the very least, if I top line something as reactive lymphoid, that I maybe would raise certain other differentials associated with that. Okay, so you see a needle core, an excision on your microscope stage or digital screen. Um, and you see Castleman-like features, right? So that's what you have. Or if you get a bone marrow, you get plasmacytosis with megakaryocyte hyperplasia and reticular fibrosis. What do you do? Um, so first, what do you need? And again, I say this, I've been very fortunate to work in an academic setting where I have all these toys, but um, typically, if hopefully if you have this, then I would say that you're almost there in terms of at least being able to confidently address this. But in terms of wish list items, hopefully you have access to EBER testing, HHV8 immuno, both serologically or the immuno, IgG4 immunos, both IgG4 and IgG, kappa and lambda, or any of the other plasma cell aberrancy markers, bug stains, right? Again, those are probably way more common than any of these entities. And so that's the reason that I kind of posit that hopefully you'll have these available for you. And then I usually would have to go back to the CDCN criteria to look for the other things. Again, you've got the two major criterion, hopefully at this point. The rest is just those criteria. So going to clinical notes, your history, and things like that. This oftentimes, at least the ones that I've seen, there's always some kind of version of being labeled, of the patient being labeled as a medical mystery. So it's kind of nice actually from, at least from the pathology side of things, that you're the one that kind of helps shed some light into this and kind of solve this medical mystery. So I find that quite gratifying. And often these patients have an acute presentation with the fever and the anasarca. And so hopefully you can at least go through some of these lab findings to help inform your workup as much as possible. Okay, and so this is what I mean by, um, sorry, should go back. Yeah, okay. Let me raise this question because again, it's one of these community questions um, that I'm always interested in finding. So when you see a reactive pattern on the lymph node, what do you do? And again, this is, this is depends on where you are. If you have all the nice toys, fancy bells and whistles made available to you. But I'm always curious um, how you would approach a reactive lymph node. And I can tell you my experience as well after this. Again, not there's no right or wrong answer. This is not, for judgment or anything like that. I'm really just curious in terms of how people handle reactive nodes. Yeah, so a majority would perform a baseline type of workup, plus or minus flow, and then sign out. And honestly, I would probably fall within these two categories. Um, Certainly when I was a junior staff, I was a lot more nervous, and I think I would work it up quite extensively. Um, but I think as over time and you get more comfortable, I think I would fall into this. And sometimes, dare I say it, I might actually just um, go with this third category here. Sorry, what do I have here? Oh, I don't have it. Yeah, sometimes I would just if there's some flow cytometry, sometimes yeah, I'd be brave enough to actually sign it out just based on the flow. I know that might be sacrilegious to some or blasphemous to some, but once in a while. But I would say that yeah, most of this I would fall through here. Um, that's interesting for the Center for Clonality Studies, because especially depending on where you are, if you have access to timely clonality studies, sure, and hopefully affordable and cost beneficial. But yeah, so thank you for that. Like I said, I get a lot of information based on these community type of questions. And so just going back to the slide, again, this is just a slide from a recent publication that looked at the presenting symptomatology for IMCD. And it, bottom line is it's everywhere. So this is why they get labeled this kind of medical mystery. But I think the commonality is this kind of inflammatory look to the patients, which admittedly is very different for like a typical MDS, right? Or a plasma cell dyscrasia when they would come in. And so that's really probably the most common, the commonalities between these patients. And so this one is also a very nice one because it tries to map the different classification systems with the histopathology. So it's a bit of a busy slide, but if you can see here in the top part where you have those different classifications, it's kind of neat that it sort of maps to all these H&E changes, right? Where you have the unicentric, for example, let's take the simplest one, where it really maps towards more the hyaline vascular end of things, the regressed germinal centers, etc. And then you've got on the other extreme, you've got the HHV8 associated ones where they're more of the plasmacytic, plasmablastic even look to certain things, especially in the HIV type of setting. So that's the other extreme. The challenge is this middle part, as you can imagine, right? Where you have more of the mixed morphology and overlapping clinical features and things like that. So um, that's why all the other investigations or ancillary tests that might be available, hopefully, is something that can be accessible to everyone, both clinicians and pathologists alike, to at least help better inform the workup available. So yeah, so just some key takeaways is that reactive lymphadenopathy requires careful consideration of differentials, especially when you have these Castleman-like features that are seen. The IMCD diagnostic criteria can provide this standardized framework. TAFRO, again, not uncommon. I mean, I'm starting to see it more, and I don't know whether I'm seeing it more because it's becoming more recognized. But these have come up quite a few times already for me. So, and then IPL, still waiting for that one, but I think it's just a matter of time. Um, and yeah, just going back to the learning objectives, I think we reviewed the IMCD diagnostic criteria, explored some differential diagnosis, and then introduced the concept of these TAPRO and IPL entities. And I think that's it.
Perfect. Thank you so much, Carlo. That was really informative. And reactive lymphoid hyperplasia can indeed be a very challenging diagnosis, and it does require careful consideration and various differentials. And you beautifully highlighted Castleman disease, Castleman-like disease, IPL, TAFRO, all these complex differentials. So thank you so much. So I'll open the floor to the audience for questions. And then, Carlo, you have cases
I
to
do.
discuss.
I
Sure.
do.
So
And I'm just reviewing the chat here, so thank you all for the chat and the lively discussion happening, and I agree with what's being said here. So thank you all for being so engaged.
any questions from the audience with regards to the Castleman disease topic that Carlo has just given? So there are comments, amazing pictures by Taban, and the question that I have actually, Carlo, is how frequently do you get bone marrow specimen for Castleman disease in your practice?
Yeah. So the couple of times is because they would present with lymphadenopathy. And so they would do the marrow in the hopes to rule in or rule out lymphoma. So that's when I would get marrows for Castleman. Not because they're trying to stage Castleman, not that it's a staging kind of thing, but you know what I mean. It's really more when the case is undifferentiated, they're seeing all these lymph node stations that are enlarged, and so they would marrow. And I kind of half jokingly said there, like, why would you diagnose lymphoma with a marrow? Um, because really it's a tissue diagnosis in my opinion. And so it's that's the only time that I would get um, a bone marrow biopsy in the setting of Castleman. I've seen it both where there was a diagnosis of Castleman and then they would marrow because they don't believe that it's Castleman or something like that. And so you would do that. I've also seen where they did the marrow first because of all the cytopenias, because as you know, all it takes is like a little bit of macrocytic anemia, you get a marrow, rule out MDS. And then you find that the other lymph nodes are also Castleman. So I've seen both scenarios play out in my practice.
Great. Thank you. Okay, all great comments. Thank you, Dr. Hojilla, for a truly excellent review today. So I think, Carla, we can go ahead with your cases.
Sure.
Thank you.
Oh, I just wanted to say, I think I've seen at the time the notion of IPL, at least I wasn't aware of it, but I think I have seen a case that may have been that. And it was sent, it was a bone marrow that was sent for query triple negative MPN because basically the platelets were just like rising through the roof.
Yeah.
And so but it wasn't quite clear in the marrow what this was. And what struck me when I was looking at it was the plasma cells, like polytypic plasma cells, quite striking. Like,
Yeah.
could have thought it was a myeloma, but it was perfectly polytypic. And going back, there had been lymph node biopsies that were called reactive. And so this was reviewed, and in the end, there was increased plasma cells, but when I was showing it around the lymph node, people were found it a bit underwhelming in the sense that nobody was like, I would have jumped to say Castleman, but plasma cells were increased. And it's just also, she was very, very sick. She had inflammatory, and they found IL-6 was increased. And so in the end, she was treated and she responded. Apparently, like the response was quite striking.
Yeah.
She went from like heart failure and
Yep.
extremely sick too. So it's just to say, like, it may come up in that
Yeah.
way.
And the few cases of TAFRO that I've seen as well, very similar, slight variations. But what's amazing to me is that the cytopenias go away even with a corticosteroid pulse, right? Which you just don't see in any MDS. or triple negative MPN. And so that's a big clue as well when patients all of a sudden feel better with corticosteroid therapy. Anyway, so thank you for that contribution, Rosemarie. I just wanted to highlight, I think, and forgive me, like I have some Castleman cases, which are, I think, pretty textbook, which is great. But I think I just want to highlight two things. Oftentimes, just because of the nature of modern pathology practice now, we often get lymph node cores. And I just wanted to highlight, often we'll just see these type of findings. And it's really, really challenging, in my opinion. This is actually one of the better lymph node cores for Castleman that I have that I would actually feel comfortable calling Castleman. But if you're not used to this, really what you have are the hypervascularity that you would see here, right? So all these are that high endothelial venules. You've got a nice regressed follicle here. And I say that because I can start to see some of the onion skinning. But, someone might say, well, how do you know this is not just a primary follicle, right? And that's fair, I think. But again, the constellation of this hypervascular, or at least the increased HEVs in the background, is not really. And then, you start seeing things like this, where the train tracking or onion skinning and that atrophic one, atrophic looking follicle is a bit more pronounced. So overall, it's not bad, but I'm sure if my colleagues can also talk about their experiences, it's not uncommon that you get these types of cases where, is it Castleman? It didn't read the textbook nicely. Maybe it could fit, but certainly it's problematic. And again, if you look at the low power, this is not a bad core, right? Like most of the time, when you get at least a centimeter and a half, that's actually pretty good. The other times it's really very small. But again, I'm preaching to the choir here. I think we all would want to have excisional biopsies, but such as it is, this is the nature. And if you do get these types of cases, then this is where I'll be very careful in terms of top lining, or at least what you're going to top line this as. Like I said, for me, I was quite confident to call this Castleman, but I completely understand where there might be some equivocation or signing this out as, descriptive, quote unquote. Whether I would use Castleman like in my terminology here, again, I personally do not. It's all or nothing for me. I might couch it in, describing all the fact, how do you say Castleman without saying Castleman disease or something like that? So yeah. So that's the first case. I'm not going to show you the immunos and things like that, because I think the point here is that it's a very tough diagnosis on limited tissue sample when you really need. Like in this case, this is a classic case. You've got a nice excision, and as soon as you go in, you've got all the features that you would expect for Castleman, right? Even on low power, right? These are not neoplastic follicles that you would see in follicular lymphoma, for example, but you've got a nice twinning right here in the middle. And you've got those hypervascular vessels within the germinal centers as well. But again, this is the luxury of having an excisional biopsy. The second case that I have is actually a Tafro case in the bone marrow. So this came in as query MDS because of the anemia and the thrombocytopenia. But you look at, and sorry, that's how I first got it. And sure enough, I look at it and it's like, oh, this is pretty hypercellular for, I think this is a 50-year-old. And, even on low power, it's looking like could be an MPN, right? Marrow is packed. And indeed, on higher power, you've got megs that they don't look the healthiest, right? You have some big ones here, some small ones here. Not so much in the way of crowding, but and you have some granulocytic hyperplasia. So, at this point, I was like, okay, Could it be MPN? And you look at it, and then on more careful examination, you start seeing plasma cells. So here, right around where the vessels is where you typically would see them, but there's just more of them. The next slide is the retic, which is even more impressive. And you're thinking, could this be MPN? So yeah, so at least MF1, maybe F1-2. I know people don't like 1-2, but you know, it is what it is. And the MEGs, you know, it's not as scary anymore. Initially, I would think that there's actually more, but the last one, what do I have here? The plasma cells. So scattered, increased. Certainly, when you see this level of plasma cell, right, I think you'd agree you'd want to work out that these are not monoclonal. Quite impressive plasma cells in here. So these are all polytypic. They're not IgG or IgG4. And sure enough, when I did a bit more digging into the history, all the symptomatology, so fever, remitting kind of type of fever, the fluid overload was not. Wait, I'm confusing this one on the case. I believe this one was the one where it was a bit more subtle, and it's only on radiologic findings that they found some slight fluid collection bilaterally in the chest wall. What else? And then, of course, there's the reticular fibrosis. And then proof in the pudding was I got the lymph node not so long after this, which actually showed multicentric or at least Castleman disease. And yeah, that's what I have.
Thank you so much, Carlo. That's great. Any questions from the audience? Okay. Can I ask you a simple question? For your case number 3, what was the clinical indication when you got your bone marrow biopsy? Query TAFRO or
No, query MDS.
Query MDS. So, Carlo, did you end up in sending it for NGS or the JAK2 Maple color? Were they done? Because you'll rule out all the sinisters first before reaching the end. Thank you.
So I guess it depends. I tried very hard to stop it. But as it stands, and again, depends on where you work. Sometimes these things are automatically done. And I think this is where I have to advocate that for pathologists, especially, right? If again, I hope I'm not offending clinicians who are in the audience, but I'm completely against just checking off everything in a requisition form when you submit a marrow sample, right? You know, check everything, MPN, myeloid MGS, clonality studies and everything. You just can't, right? Like I'd much rather have a model where you just have these things banked and nothing is activated automatically. Unfortunately, I work in a center where we don't really have a dedicated heme, so a lot of these things are kind of automatically updated. As soon as I saw this and I kind of smelled that picture, like that inflammatory picture, yeah, I was on the phone trying to cancel these tests. But it ended up, yeah, like the karyotype, as you would imagine, is normal, and NGS was negative. No significant variance detected. Yeah. Now, would I have asked for serum IL-6, right? So again, it's these things now, or at one point we could be doing a really good job at kind of gatekeeping a lot of these type of unnecessary tests, but then we have to decide now, right? Where do we put that extra effort, or how does our gatekeeping? I'm a firm believer that the gatekeeping for all these expensive tests and timely tests should be on our end rather than the clinician end.
I 100% agree with you. That's what has been done in the community hospitals as well. They're automatically generated by the hematologist, but then we have end up in trying to put some control by extracting the DNA and banking them and activating at our end as well. But mostly they are done before the sample reaches us. So that's unfortunate as well.
Another simple, much more simple scenario is mid-88, for example, MYD88. And, just because someone has IgM spike in their serology, like oftentimes, like, did you send for MYD88? I'm like, no, because I don't know what kind of lymphoma it is. It's one of these things. Sure, if it looks like LPL, then yeah, I'm gonna send it. But as we all know, LPL and marginal can have MYD88 expression. It doesn't really help. But again, it's asserting some level of gatekeeping. I think that's really important, especially as these tests become more and more complex and honestly more and more expensive, right? So
I have a question in the audience. What did the CBC show for the last case?
yeah, so anemia and thrombocytopenia, and I believe the platelet count was around 50. Yeah, for this one.
Thank you. If we have time for one more question.
Of course.
For the first case, Carlo, how did you sign it out, the biopsy case?
Oh, you're gonna love this, but I signed it as most in keeping with Castleman disease, and then a long comment saying that, these are the things and why I think it's Castleman disease, and ideally that it should be done on an excisional biopsy. I'm not shy anymore. Like, for example, for that Tafro case, I just said, I need a lymph node. Please do not send me a needle core, send me an excision, because that's how you diagnose Castleman disease. So thankfully, yeah, they sent me an excision. So
That's great. Thank you so much once again for giving us an amazing talk. We all learned a lot from you. And with this difficult entity, now you have made it simple, which is great.
did I do?
You did. There are great comments in the chat box from all the audience as well. So we have cases from the community, and Rosemarie will take over. Please don't forget to fill out evaluation for Dr. Hojilla's talk, and because your feedback is really important to us for shaping us the Hematopathology CCLI series. Thank you so much again. Rosemarie?
Yeah, the link for the evaluation will be put in the chat at the end of the meeting. And also just a reminder that you need to fill it out to get your CME certificate. So now that the housekeeping is done, so first we had Sarah Morgan, who had a case to present. Sarah is from Oak Valley Health, formerly Markham Stouffville Hospital. So thank you, Sarah, for bringing a case for a discussion.
Thank you so much for the introduction. Thanks, Carlo, for an amazing talk. So I chose a talk that's relating to what Carlo has just mentioned. It's a case that I got last year at Markham Stouffville Hospital. So this is a 29-year-old male patient who came to the emergency department with a left groin swelling that he felt himself, and he had no fever or other constitutional symptoms. And when he came to the OR, all what they found clinically was just this enlarged mass or enlarged lesion in his left groin. Initially, they thought, would this be a hernia or would be something else? They took medical history. The patient only had the history of psoriasis and hemorrhoids. So they went ahead and did an ultrasound and some laboratory tests. The laboratory tests showed that the CBC was normal. ESR and C-reactive protein, which are markers of inflammation, were mildly elevated. And the patient he was not admitted, but he was being seen in our hospital over a year. And he was seen by those clinicians. So he was seen first by the Rapid Assessment Oncology Clinic, which patients are usually sent for when they have a lymphadenopathy or a query malignancy to be worked up the fastest possible. Also, infectious disease were involved, and finally, hematology. So an ultrasound was done from the ER, and as we see, the ultrasound is showing a big mass in the left groin, and they suggested that this mass is most likely a lymph node. The lymph node was not having an echogenic hilum, and the size was about just less than 5 centimeters. The patient went ahead and did also other series of imaging. So he did a CT chest abdopelvis, and only the finding that this patient had was left inguinal lymphadenopathy, and otherwise the CTs were unremarkable. So I'm showing you the timeline because I'm not the only hematopathologist at Markham Stouffville, but for some reason I got all the surgical specimens for this patient. I got 3 of them. So I'm gonna show only 2. So this patient presented to the ER in December of 2023. And then until all the investigations were done and they decided to do a lymph node biopsy, I got the first lymph node biopsy in February of last year. And I looked at it. I couldn't pull the case because it's in our archives, but I'll show you the case after, which looks pretty much similar to this one. So I signed this out case as reactive lymphoid hyperplasia. I did few immunostains, and we sent our cases to Sinai. Carlo signed this out for us, the flow cytometry as negative, no evidence of lymphoproliferative disorder. Because they were worried also about infectious etiology, I did a couple of special stains, ZN and GMS, and there were no mycobacterium or fungal organisms. And that was it for me at the time. The patient still had this persistent lymph node enlargement, and you can imagine that 5 centimeter is quite a big sizable lymph node, and the patient was not comfortable having it, and it was not going away for some reason. So the patient was seen by infectious disease. He had all this battery of serological and microbiology tests to rule out all possible infectious disorders. As you see on the screen, you can name it, but everything was done and it came back negative. So again, because the patient was not resolving, the lymphadenopathy was persistent and they had no clue why it's happening, they sent me another core biopsy in August, so within 6 months of the first one. And this is the one I'm gonna show you now. So I got the core. I apologize that I do not have a scanner, so I don't have a whole slide image, but the lymph node core looked like this. You could barely see the normal lymph node architecture that we are used to, but at the same time, there is nothing monotonous or nothing worrisome, no large cells. It's mostly composed of small lymphoid cells. And as you can see on the image, there are some hyaline vessels, but not that much to light something or to tell me this is Castleman or whatever. So I just thought it's some sclerotic bands with a normal looking lymph node. This is a higher power. And I was looking thoroughly to see, do I have anything else to think of? And I don't think I had anything that would help me get into a lymphoma or other disorders. This is another view of the lymph node. All what's standing out is the hyaline bands and some high endothelial granules. So I did some immunostains just to back up my morphological impression or my H&E impression. CD20, as you can see, it's not diffusely increased. CD3 was also just seen in the background, some reactive T lymphoid cells. CD5 was almost similar to CD3, and I go back to CD3 again. So that's how CD3 is looking like. But CD5 had something that I did not like. I don't know if you can see a tinge of positivity in the background cells. And I wasn't sure if this weak CD5 positivity was on the B cells or on something else. But I was a bit worried from this look of the CD5. So this is the comparison between CD3 and CD5. CD5 slightly more. BCL6 highlighted rare germinal centers. BCL2 is showing that those germinal centers are negative for BCL2, so there is no follicular lymphoma or anything to worry about from that perspective. Ki67 was pretty low in the range of 10% maybe or slightly more, and it's more accentuated in the germinal centers as expected. I did cyclin D1. I always do it in any panel of small B-cell lymphoma, but it's important in this case because if you have CD5 positivity, or if you're suspicious about it, certain differential diagnoses come up, like mantle cell lymphoma. Is this a marginal? Is this a CLL? The patient is young. This doesn't look like a CLL, but cyclin D1 at least ruled out mantle cell lymphoma. Unfortunately, in this second biopsy, they did not send a flow cytometry. Maybe if they have sent a flow, I wouldn't have gone crazy with immunos, but I don't have a flow cytometry with this case. So cyclin D1 was negative, and then I went ahead and did 23 and 21. 23 is also not extremely abnormal. It's just highlighting some primary and secondary lymphoid follicles. And CD21 is slightly expanded. And I was thinking, could this be nodal marginal zone lymphoma? And when I looked at high power, I was imagining, could some cells be entangled with the follicular dendritic cell meshworks? And also the CD5 weak positivity made me scratch my head, is this a marginal zone lymphoma or not? And because this was the second time I get a biopsy from the same patient with no clue about the diagnosis, and I don't have a flow cytometry, what I did is I sent the case for two things. I'll show you in the next couple of screens. So CD130, it showed few plasma cells that were polytypic. I didn't put the kappa and lambda here, but they are very few, and they are polytypic for kappa and lambda light chains. So when I had this thought, could those be atypical B lymphoid cells? I just talked to the clinician and said, it looks reactive. It looks exactly like the first core biopsy, but because I don't have flow cytometry, I'm going to send for extra or additional tests. So what I did was sending for SOX11, just because some mantle B cell lymphomas are negative for cyclin D1. I sent for SOX11, and I got the same back, and it's negative. And I thought, if this is a nodal marginal zone lymphoma or any indolent CD5 positive lymphoma, I sent for B cell clonality, and it came back not negative. There are no clonal peaks. So with that, I was comfortable that this is still a reactive lymphoid hyperplasia. I don't have enough to make it a lymphoma or to make it any other thing. And I said confidently, this is negative for a lymphoproliferative disorder. Again, the patient still had this persistent left inguinal node, and no other lymphadenopathy came up, nothing constitutional. The patient was feeling well, CBC remained normal, inflammatory markers were slightly increased. They sent interleukin-6. I know that Carlo sent, if you know a place, tell us. I have to go back to our LIS and see where interleukin-6 was sent, but it was sent outside our facility, and it came back negative. And it was prompted by the clinician. I did not ask them to do interleukin-6 in this case. So again, this is the last and third time I get a lymph node from this patient, but that time they did the right thing. They did a lymph node excision, or they did an incisional biopsy. Actually, the surgeon said that the lymph node was tethered quite hard due to fibrosis, and so they got part of it out. And I'm going to show you what I got this time. This is just how the lymph node looked like on the slide. So at grossing, the lymph node was 5.3 centimeters, but it had a fibrotic center and a quite thick capsule. And this is how it looked like. On a low power, it's showing a lot of lymphoid follicles. It has a lymphoid follicular hyperplasia-like picture, where you can see on the screen there are a lot of follicles. Some of them are primary, some are secondary, and you can still see this hyaline vascular look or fibrotic look that we saw on the biopsy. Another closer view where you can start here, maybe appreciating some of the onion skinning around the mantle zones of those germinal centers, and still the hyaline vessels are so prominent in this case. This is another view where you can see that, okay, we do have hyaline vessels or high endothelial vessels, I mean, in the normal lymph node, but they wouldn't be that fibrotic, and they wouldn't be that many. So I think this view is showing a lot of this hyalinization on the upper right corner, and it's showing some of the vessels, which I will get to in the next few slides. This is the dense fibrosis that was in the capsule and in the central lesion of the lymph node. And just mirroring the features or the hallmarks that Carlo was mentioning about Castleman disease, this is nicely showing a regressed germinal center or an atrophic follicle, where you can see the center has less follicular dendritic cells than supposed to be in a secondary germinal center or in a secondary follicle. And as you see, all those hyalinized vessels, some of them are traversing this follicle. This is another nice view of what we call a lollipop appearance, where you can see some of those vessels are getting into the germinal center and crossing this mental zone that looks like onion skin. This is another one that really looks like a lollipop in the center, and you can see that the mental zones are quite expanded and have this concentric appearance. This is also another closer view, and you can see how prominent and hyalinized the vessels are throughout the whole sections that I was looking at. This is the twinning that we mentioned as a hallmark as well, and one of the features that we might find. You can see in the center there are two germinal centers that share a common mental zone, which is a nice feature to find. And again, the same features, hyalinized vessels traversing the atrophic follicle. So when I saw all those features, I was pretty confident this is now a Castleman, which was not evident at all. And it shows the power of lymph node excision when you are not sure with a lymph node biopsy. I did SMA just because I wanted to highlight the amount of vessels I have. It's just for my curiosity. I don't do it as my regular panel for lymphomas, but it just shows how much the high endothelial venules are proliferating in this case. I did CD138 because when Castleman came to my mind, I was trying to think, clinically, it looks like a unicentric Castleman, but is it a plasma cell type? I know that the features are pointing out to a hyaline vascular type, but I just did CD138 for completion. Very rare plasma cells, and they were polytypic for kappa and lambda-like genes. I also sent out for HHV8, which I don't have at my facility, and it came back negative. So I know that Castleman is an H&E diagnosis, but I just did a few immunostains to back up my diagnosis, and they don't show much, just some germinal centers that are BCL2 negative. And again, here I'm finding the same thing which puzzled me the first time. Why is CD5 slightly greater than CD3 with no clonal B cells? And I'll answer this question later in the talk. So again, CD23 is highlighting all those expanded follicular dendritic cells around the follicles that are expanded. Ki67 is not elevated. It's also mirroring the secondary follicles with germinal centers. There is something in the WHO which I tried to open it in this case because I was finding some cells which are on the left side of the screen slightly larger than the small lymphoid cells, which I thought are plasmacytoid dendritic cells. And these could appear in collections in the interfollicular areas. So I sent out for CD123 just to highlight them for my own learning. It's not essential in the workup, but I did have a lot of aggregates that looked different than my lymphoid cells, and these were all plasmacytoid dendritic cells. So in the end, I was happy I got to a diagnosis. This is unicentric Castleman disease, hyaline vascular type. And the only way to diagnose this case was through excision, because as you've seen, the lymph node core did not show much in this case. So the take-home message is lymph node excision is often the diagnostic specimen in cases of Castleman, because you need the architecture, you need to see all the findings to make your diagnosis and to exclude also parts of the differential diagnosis. And the thing that I found to answer my questions of the CD5 was that mental zones that are expanded in Castleman disease are composed of BCL2 positive B cells that also can exhibit dim CD5 expression. So all those CD5 were expanded B cells in the mental zone that were picking the CD5 slightly more than the CD3, but I had no clue about it on the biopsy. And I started to think of B cell lymphomas, but in the end, it was just part of the expanded mental zone in Castleman. Thank you.
Thank you, Sarah. That was a great piece, and your images of the excisional biopsy were quite nice. And as you said, I think it really highlights why excisional biopsies, even though sometimes it's difficult for the clinicians to get access to them, depending on the center where you're at, like it can really be helpful for those tricky cases and persistent adenopathy. Was there any question in the audience? If not, we could move to our next presenter. Alexandra, do you want to share your screen?
Yes, 1 second.
While you do that, I'll just introduce our next presenter, Alexandra Pariga. Hope I didn't massacre your name. Yeah, who's a surgical pathologist at the Ottawa Hospital and the lymphoma subspecialty lead.
Is that mode? I'll turn on my camera. How do I share my screen with you guys? I'm not sure how to share my screen.
Should have, I think, Jenny, we gave.
Oh, there it is.
Yeah, so the share button is at the bottom.
Yeah,
you should be able to share your screen.
I got it now. I had my presentation in present mode and I couldn't see the other buttons. Okay, so you guys should see my presentation now.
Yep, we hear you, we see the presentation. Thank you.
Yeah, I put this together pretty quickly last night. I thought it's an interesting case I happen to have sitting in my office. I had intended to take photos of it and hadn't yet, so this was a good opportunity for that. And it's related to the topic we're discussing. So this came to me over Christmas, actually. It was a consultation from a community hospital. And it came initially as reactive lymph node, was the initial interpretation, but sending for consultation. And it was I knew it was a 73-year-old male, and this was a right inguinal lymph node, and the clinical history just said query lymphoma. And there was no additional information at that time. And so on low power view, it was a large lymph node, and you could see what looked like from a distance, reactive sort of follicles. But you could also appreciate a proliferation of small vessels around those follicles. And then looking at the follicles, they look very odd. Some areas, I questioned whether or not they're twinning. In the interfollicular area, there were tons of plasma cells, as well as these small vessels, a little sclerotic. You could see follicles with penetrating vessels, and kind of looking like a classic lollipop. There are areas of follicles with proliferations of these pale cells, monocytoid or cells of clear cytoplasm at the periphery of the follicles in some areas. Reactive. And then here's a higher power view of the follicles themselves. And so you have these penetrating vessels. You've got some scattered larger cells. Don't want to give it away. And then these would be the mantle B cells, and then some monocytoid lymphocytes. And this was sort of the view of what the lymph node looked like. And so we'll go to our first quiz. Okay, so it looks like most people got it. So this was the key stain. So like the first stain I wanted to see was, of course, HHV8. And indeed, there's a lot of HHV8 positive plasmablasts or infected lymphocytes. So those atypical lymphocytes, or sorry, they're actually plasma cells, but infected plasmablasts at the periphery of the follicles in the mantle zones were highlighted by HHV8. And so here's another lower power view of the pattern of the HHV8 positive cells. Surprisingly, I did a concurrent EBV, and the interfollicular, some of the follicles had a lot of EBV positive cells, which really surprised me because I don't associate multicentric Castlemans with EBV positivity. On low power view, this shows the EBV and the HHV8. So the EBV infected cells were distinct from the HHV8 infected cells. So these are the same sets of follicles, and we can see the one that's EBV positive is negative for HHV8, and then the HHV8 cells are still staying sort of more around the follicles. And then the EBV, there were like maybe 5 follicles that had EBV positive cells, and then there were all these like single scattered interfollicular EBV positive cells as well. I'll also show you a lambda and kappa-ish. So the HHV8 correlated with lambda expressing larger infected cells. Versus the plasma cells in the background where kappa lambda showed a normal pattern of kappa lambda expression. And so on low power, if you're not careful, you could quickly just interpret this as no lambda restriction. But when you closely look for the HHV8 infected cells, you can see they're lambda positive. In addition, in the subcapsular sinus was the spindle cell proliferation of cells that were also ERG positive and HHV8 positive. And so now, what would your favorite diagnosis be? Okay, so most of you got it. And this is a tricky one because we don't see these types of cases often with HHV8 positive or like lymphomas from this category. But the final diagnosis for this case was HHV8 associated multicentric Castleman disease with increased EBV positive cells in keeping with reactivation of EBV and Kaposi sarcoma. And I'll admit I struggled quite a bit with this. I had to review the diagnostic criteria. And although I did consider HHV8 and EBV positive germotropic lymphoproliferative disorder, in that disease, the same cells are co-infected with EBV and HHV8, and here they're clearly in different cells. The patient, interestingly, hadn't been tested for HIV, though he did have risk factors, and clinically he wasn't feeling unwell. So I did send the case to NIH, and Elaine Jaffe did review it, and she agreed with the diagnosis. And so just to quickly review, in the WHO Blue Book, HHV8 and associated multicentric Castleman disease is a lymphoproliferative disorder that requires the characteristic HHV8 infected plasmablasts, and these are always lambda restricted, which is just an interesting feature to know. And you often have idiopathic multicentric Castleman-like disease morphology in the background. And then, but also clinically, patients typically present with a systemic inflammatory symptoms due to a pro-inflammatory hypercytokinemia. And so like the only other, this is my third case I've seen. The other two cases I had, both were in the ICU. One, and then both died very shortly after the diagnosis. However, this patient is still doing well and hasn't yet received treatment, but is considering it. And he did, actually, I'm not sure if he tested positive for HIV, but I suspect he has it. So co-infection of two viruses. So it has been noted in the literature that you can get co-infection with different viruses, especially in patients that are immune compromised. And in these cases, you can either get infection in the same cells. So for example, in primary effusion lymphoma, but in some cells, the co-infection does not act synergistically, and you can get cases of sort of separate cells that aren't infected or are acting independently. And so that's what this was interpreted as. So yeah, that's everything I have. Any questions?
Thank you. That's quite a case. We don't see those very often.
Yeah.
Any other questions from the audience on for any of the people that presented, or just general questions about Castleman? And just to remind you, Jenny just posted the link for the evaluation, which you need to fill out to get your CPD certificate. Yeah, a lot of people just thanking the presenters for interesting cases. Yeah, I don't see any other comments in the chat. So yeah, I think I just want to thank everybody who presented, Carlo, Sarah, Alexandra. I think it was very a great review of these interesting entities that are rare, but I must say, as we kind of expand the understanding, I feel like we sort of see it more and more. So sometimes it's kind of a case of when you look for things, you can find them. And especially now with new drugs being available, I think it can be quite useful to suggest the diagnosis, because there could be some therapies available. So yeah, I think it was a great review, and I hope everybody enjoyed it. So without further ado, I think we will adjourn our meeting.